one of the things that I know the ILC Foundation has started looking at is looking at with the Center for Clinical or Effective Practice is creating a kind of a roadmap, assessment sheets, best practice guidelines. Has there been you've had the feedback that it'd be beneficial with it? Has any of that work started? And because we're just starting that work ourselves here in Ontario.
Yeah, I think that's a great question. I think we definitely alluded to developing guidelines several times throughout the presentation. I think that would be a lot of the survey participants really requested guidelines. I think that's a big thing in medicine now, to have that to really give you an idea of where to start, what to do, what to think about. There is some work in that area that has been going on, but has not really resulted in an identifiable product at this point in time. But I think, to your point, there are lots of different groups thinking about it, and it would be really nice to probably get a bunch of the groups together and just hash it out so that we have it, instead of everybody kind of doing their own work in different areas of the world.
That's great. Thank you.
We have another question from Sharon. In Canada, there is not a specialty service that seems to provide a home for EDS patients, does not fall to rheumatology. If I refer a patient to rheumatology, they decline and suggest try physiatry. This is for newly diagnosed adults. Is this the same internationally? And then she says maybe in the UK. I don't know if you can answer that one.
Yeah, my experience as a rheumatologist has been that most rheumatologists, pediatric and adult, don't feel that EDS falls under the rheumatology specialty. Since it's considered a genetic disease, most feel that genetics or geneticists should manage or at least diagnose and manage patients with EDS. But what we have found is that really geneticists are more diagnosticians and not as involved with management. And so then these patients are kind of falling into this gap where no one is owning them or is in charge of their care. Unfortunately, rheumatology is not buying in right now. That has been my experience. I personally feel that as a rheumatologist, with our knowledge of musculoskeletal health and rheumatic disease background, that we could be very good, at least team members in the care for patients with EDS. And I think that that's the way our multidisciplinary care clinic is set up. But I don't know that that's going to be an easy sell. And we certainly have not seen a lot of buy-in at this time. So Dr. Black and I's approach has kind of been trying to identify primary care providers who maybe patients already have a relationship with and trust, and then educating them so that they can maybe kind of own the patient and be the advocate and the one that's managing and referring them appropriately.
That's great. From Monica, my doctor asked for a 5-minute summary of EDS as found in your study. Do you have such a tool that a patient can provide? We also need to walk a line of not being seen to be relying on Dr. Google, which has caused friction with my GP.
Yeah, I think the short answer is no. We do not currently have a 5-minute summary that we can hand out. We are currently in the works of developing these things. This first part was kind of seeing what needed to be, what that knowledge was out there, so that we could start kind of meeting people where they were and developing those things. I think it would be great to have something quick and easy that a patient could give to a provider. I do think it's a tough position for a patient to be in, because I have found that sometimes when the patients come in and are very knowledgeable or even know more than the provider, that can be kind of an odd relationship, or kind of put a provider on their heels and make them uncomfortable. And so it would be nice if we could, educate providers so that they are aware to some degree and then also have something that patients could easily access that they could then give to providers if need be to kind of come from both angles. Bill, do you have any input on that?
I do. I think in line with the work we've done so far is we try to be not only deferential to the providers to ensure that we are asking the right questions and providing the right information, but we try to do so in a way that's iterative. And so we work a process, get some answers. We also obtain additional questions. And so even just kind of thinking about right now, it's like if we were to put together a one-page handout, I think we could probably do a pretty good job of putting information in that we think providers want to know. But it would also be really important to then send it out to 10 or 20 providers in our area and get feedback and say, what else do you want to know? Like if a patient brings this to you in clinic, what is it that you're wanting to see in these handouts that in the session you can look at quickly and gives you the guidance and answers that you want. What I suspect, what we might find is that it varies based upon the patient's disease presentation. What they're presenting to clinic with might well drive the kinds of questions that a provider would want to know. So even within this, I think as good research should be, it's hypothesis generating and will yield additional work as well.
That's great. It is really about those interactive moments and that communication and the conversation, and then building on it and seeing where you're going and how useful it is, right? And then it will shape based on the need and the community. So this is from Sky. Patient side here, what are the best practices for driving improved communication with primary care physicians and specialists to improve the fractured healthcare and treatment plans that so many of us deal with?
Yeah, that's a good question. I think the first part of it, improving communication, I think one would probably be from kind of a provider standpoint. I think it would be good if you let the provider know kind of a heads up of what maybe you're needing for the visit. I don't, every practice is run a little bit differently, but I think a lot of primary providers at least have very little time and can't go into the depths or meet the needs that a patient has in maybe 15 or 20 minutes. And so if you could give them a heads up that maybe you want to discuss something a little bit more in depth so they can maybe create more time for you, that would maybe be part of that. I think the other thing that I always am telling our families is that probably the biggest thing is just having a provider that's willing to listen. There are definitely some that are kind of set in their ways or don't really want to take patient information that's given to them. And so just finding somebody that is willing to listen to them, take them seriously, and kind of start to develop that relationship with them. I think there's nothing wrong with identifying a relationship with a provider that's maybe not working and moving on. That's fine. I think you do have to be careful with that, because if you do that too often, then you can that can kind of start to look bad on the patient side and kind of start to cause providers to maybe be a little concerned. And then let's see, what was the second part of that question? Let me look back here. And then communication with primary care and specialist. So the second part of the question is about the communication between primary providers and specialists. This is a long-standing problem that, especially in the US, that we have with different providers having different electronic medical record keeping systems and different processes for how the referral works, how consultation works, where a provider will put a referral in, the patient will be seen, and then that information is then somehow given back to the referring provider. And it's pretty plagued with problems that lead not just for people with complex EDS care, but for really any chronic problems. There's a lot of these issues that pop up. And Dr. Black, you may have some other input on that.
And I think as an extension, we're clearly focused on EDS, but some of these things that we see in terms of communication problems with specialists, how to loop in PCPs. I think it's important as a community to recognize that this is not unique to EDS. That other patient populations which have multiple comorbidities and significant medical needs have similar issues. And the reason why I make that point, because I think it's important to understand like how much of this is about EDS specifically, and then how much of it ties back into issues with maybe individual healthcare systems. And so of course in the US, we're moving more to an RVU based unit for physicians billing, mental health practitioners billing. And depending upon the discipline, it's based around, of course, patient facing care. And there's just less time even for communication between providers. Dr. Jones took one the other day that definitely occurred after hours, so it required him to stay additionally in his workday to be able to communicate with this PCP, who stayed after their workday full day of clinic to be able to talk about these kinds of things. And so if you're talking large clinic volumes, and that's fine for a one-off, but it's not sustainable for a bigger piece of practice. So I think that's important to note too, Jordan, and I agree with you completely.
Yeah, that's great. Okay, we have our last question. Once a diagnosis of EDS is made, it would be wonderful to develop a list of comorbidities that should also be screened for based on symptoms. And then based on that, have a suggested list as to what referrals should be made. Specifically, what a specialist should be aware to investigate for, and perhaps a website of the relevant association providing further detail on that screening. And this question comes from Tanya. Do you think something like that would be possible to create?
I do, and I think it's something that we are starting to work on as well. We've got a medical student right now who's about to submit a paper where this is the very case that she makes, that we in EDS we screen for cardiovascular issues as part of EDS care, but she's done some analyses from the medical record looking at the incidence of EDS in our cards kids, and is making the inverse conclusion that EDS should be something that is more commonly screened for in cardiology clinics. And so I think the more that we can make those connections based upon these comorbidities, decreases reliance on EDS specialty care like we provide, and get some more of our clinical partners and from some of these other subspecialties involved as well in becoming more aware of EDS. So I think it's certainly possible, and we can certainly, I mean, we've got the data of what the comorbidities are, of what patients report. What maybe is a little less clear is what the clinical severity of all these additional comorbidities are. Not every symptom, I think, needs a referral at that time, right? I think clinically we treat the functioning as a significant part of what we do, and if it's there, yeah, but it's not horribly bothersome, then yeah, let's monitor it, but not necessarily give you a referral for it right now. I mean, otherwise, I think probably every kid we have would get a GI referral, right? And that's a very common presentation. But instead, like we hear where they're at, and then we try and get a better idea of how impairing it is for them. Because at the same time, if we send them home with 15 referrals, that's not good for anybody, right? They can't really intensely work on 15 things at once. So this is part of our clinic. We try and help them develop a treatment plan that's really focused on 1 or 2, maybe 3 things at a time, where they can put more greater effort into and make progress in. And then we continue to add to that over time. So I think it's definitely possible. It's something we're working on. But I think it's also important that it be done from a research basis, in terms of justifying it and being able to clearly link where these associations come from.
That's great. And it's exactly, it's really looking at it as the whole for multidisciplinary teamwork. It's just about looking at it as a system, right? We're all working together. And as you said, prioritize based on the individual's needs. what is at the top of their list in that, you know, time you're speaking to them, because it can change, as our community knows, different things hit you at different times. So thank you again, Dr. Jones and Dr. Black, for taking the time to share your valuable research work with us. We appreciate this interactive time you spent with us today to answer our questions. And the ILC looks forward to continuing this connection for increasing awareness and advocacy for those with EDS. So we look forward to working with you again, hopefully.
My pleasure.
Thanks so
Thank you.
much.